Hey guys, so I'm here today, and a lovely day it is. Oh my god, Thursday, March 13th. 5 years ago today was COVID, day one, I guess. That's when Marquette told us not to come back from spring break, so that's crazy. Feels like yesterday, but it was half a decade ago. That's insane. Well, now here I am studying for oral pathology too. So today we're going to be talking about soft tissue enlargements, specifically mesenchymal soft tissue enlargements and enlargements. And so these are composed of fibrous connective tissue, smooth muscle, skeletal muscle, blood and lymphatic vessels, adipose tissue, and peripheral nerve tissue. Unless otherwise noted in the following descriptions, benign mesenchymal tumors clinically present as well circumscribed, persistent, slowly growing, non-tender, soft tissue enlargements. So here's a quick summary. There are 5 lesions that pertain to a group called the 5 gum bumps, and that is going to be irritation fibroma, or just regular like fibroma, peripheral ossifying fibroma, or just called peripheral fibroma. That's one of the POFs. There's 2 POFs. And then we have peripheral giant cell granuloma. And then we have peripheral odontogenic fibroma, which is the other POF. And then we have the pyogenic granuloma, which is also the pregnancy tumor. So again, those are the 5 gum bumps. So we're going to start talking about our soft tissue enlargements, our benign mesenchymal tumors, starting off with irritation fibroma. This is just a little summary. So irritation fibroma is, origin tissue is fibrous connective tissue. And in an irritation fibroma is a dome-shaped, firm, or compressible lesion. We have epilis fissuratum, which is also known as inflammatory fibrous hyperplasia, and that is another fibrous connective tissue lesion. And that is located, epilis fissuratum is located adjacent to flange of removable denture, and it is firm or compressible. We then have peripheral ossifying fibroma, POF, or peripheral fibroma, which is from odontogenic tissue origin. So it occurs only on the gingiva or attached alveolar mucosa. Firm, sometimes ulcerated, may move teeth. We have peripheral giant cell granuloma, which is an odontogenic tumor, and it occurs only in gingiva or attached alveolar mucosa, and it's firm and it's vascular. Next, we also have another gum bump, peripheral odontogenic fibroma, which is again from odontogenic tissue, and it occurs on the gingiva or attached alveolar mucosa. Excuse me. It is firm, sometimes ulcerated, and may move teeth. Okay, we move on from the gum bumps, even though there's one left, and we move on to lesions of smooth muscle tissue origin, and we start off with the only one, leiomyoma. And I like to remember that is because leo is smooth, so smooth muscle. It is a firm lesion, sometimes vascular, and it's encapsulated. Moving on, we have rhabdomyoma, which is a skeletal muscle lesion. And rhabdomyoma presents as a firm lesion, and again, it's located in areas with skeletal muscle. Next, we have hemangioma, which is a vascular lesion. It's a congenital lesion. It's compressible, vascular, circumscribed, or diffuse, like I said. I did not say that, but yeah, it could be circumscribed or diffuse, the hemangioma, which is like a large birthmark. We have lymphangioma, which is another vascular lesion. It is also congenital. It's compressible, usually diffuse, but it doesn't, like, even though it's coming from vascular tissue, it does not have blood in it, so it's not like vascular in that way. We have the pyogenic granuloma, and that is vascular tissue origin as well. It is vascular, so it usually will look red or purple or blue, usually red, because this is a pregnancy tumor. Benign tumor, of course. So again, it's vascular, it's compressible, maybe blanchable, frequently has rapid growth, it is ulcerated, and it bleeds easily. Okay, moving on to the next lesion, we have lymphoma, which is a lesion that comes from fat tissue or adipose tissue. It's encapsulated, it can be compressible, and sometimes it's yellow. Next, we have neuroma, a traumatic or amputation neuroma. It comes from nerve tissue. It is firm. The neuromas are usually tender to palpation. The size of the neuroma lesion is dependent upon the size of the affected nerve. Next, we have neurofibroma for the soft tissue mesenchymal benign tumors. Neurofibroma is also from nerve tissue. Neurofibroma can present as a firm or compressible lesion. It's non-tender. It can be circumscribed or diffuse. It may occur with neurofibromatosis. Next, we have granular cell tumor, and that is from nerve tissue, and it is a firm tumor. Next, we have schwannoma, also known as neurolomoma, I think. So this doesn't come from nerve exactly. It comes from myelin sheath, from nerve sheath, the schwannoma. It's an encapsulated lesion. It's firm and it's not tender. And then lastly, we have congenital epilepsy. The tissue of origin is unknown. It is a firm lesion. It is a congenital lesion, obviously, and it occurs only on attached alveolar mucosa. Okay, next we have fibroma. Okay, not next, but now we're gonna go more in depth with these lesions. So, fibroma, and I'm looking at this picture of it, and looks like it's like in like the retromolar pad area, and then behind the molar there is a big like wart, but it's like the same color as like the gum tissue, so it doesn't look like clear or anything, but it's like a big pocket of just, it looks pretty squishy. It's not like super red or anything, and I would say it's a little bit bigger than the occlusal table of that molar it's next to, honestly, like wide, pretty big. Anyways, so fibroma, so for some background on this, it's a common reactive soft tissue enlargement due to chronic irritation or trauma. Fibromas, how do they clinically present? Well, they're solitary, circumscribed, sessile nodule. That's the word, nodule. Most commonly presents as an exophytic, dome-shaped enlargement, which may be firm or compressible to palpation. The mucosa overlying the lesion may be normal or ulcerated due to trauma. Most commonly found on the buccal and labial mucosa, tongue, and gingiva. And then how do you manage or treat fibroma? With excisional biopsy. And again, remember, a fibroma, irritation fibroma, is one of the 5 gum bumps. It is also benign. Epignosis, reoccurrence is uncommon, so I'd say it's pretty good, right? And so there's 2 other lesions that fall under this category, and they're not on our decision tree, but we should probably be aware of them, I guess. We have the giant cell fibroma, and then the retrocuspid papillae of Hirschfeld. So giant cell fibroma just looks like there's a picture of the lingual surfaces of some incisors. In between, it looks like a central incisor, maxillary, and lateral incisor. There is a nodule. It looks like the same color of the gums, but a little bit lighter pink. And yeah, so it just looks like a mini little fibroma. So this is a giant cell fibroma. Giant cell fibromas are not associated with chronic irritation. 2 to 5% of all oral fibrous proliferations submitted for biopsy. 60% of cases diagnosed in people under 30. About around 50% of these giant cell fibromas occurred on gingiva, mandibular more than maxillary. Also common on hard palate and tongue. They are asymptomatic, sessile, or pedunculated. Surface can be rough or papillary obocylated, may be mistaken for squamous papilloma clinically. And then we have the retrocuspid papillae of Hirschfeld that kind of look like they would be like where tori are in the gingiva, mandibular gingiva, but then they're just kind of like little bumps. It's like behind the canines. They're found in children and young adults. Bilateral they're also bilateral, I should say. Bilateral presentation, soft tissue lingual to mandibular canines. Normal anatomic variation disappears with age, resolves spontaneously, no treatment needed, just patient education. Cool. Next, we move on to epilepsy fissuratum, also known as inflammatory fibrous hyperplasia. So this just looks like a wrinkle, like a bulge of red tissue, red pink ulcerated-ish tissue. at the buccal vestibule of the maxillary, and it looks like it's kind of like, ew, like roast beef. I'm sorry. Yeah. So Epilis, I'm picturing this girl, this like old lady named Epilis. Maybe she really likes roast beef, and she has dentures. I remember that. Okay, Epilis fissuratum. Yeah. So she has this poor lady has inflammatory fibrous hyperplasia. And this is hyperplasia of dense fibrous connective tissue due to chronic irritation from the flange of an ill-fitting denture. So how does this clinically present? Epilis fissuratum presents as an enlargement in the vestibule. Again, a fissure rolls of tissue like roast beef will be present in the lesion corresponding to the location of the denture flange, whatever, however you say that word. I assume that just means like the border end of the the border of the denture. Slowly growing, firm or compressible lesion may be ulcerated or inflamed. Management treatment: surgical excision of the mass and usually remaking or relining the denture. Prognosis: good with proper management. Next, we're moving on to another gum bump, one of the POFs, peripheral ossifying fibroma, also known as peripheral fibroma with calcification. And so this just looks like, I mean, it's gross. So like, it's like a nodule, I would say, on the lingual surface. Looks like the maxilla, maybe behind some incisors. And the gum tissue itself of like the hard palate and the gingiva, like the color of it seems a lot lighter than the actual fibroma, the peripheral ossifying fibroma. The borders of it are like really dark red, and then it kind of gradually fades to pink, and the center of the dome, it kind of looks like there's like calcification going on. There's a little like lighter, yellower. Yeah, so that's the peripheral ossifying fibroma, how this picture presents it, right? So let's read more about it. So background: common reactive soft tissue enlargement arising from cells of the PDL or periosteum. Most common in adolescents through young adults. An interesting feature microscopically is it is frequently forms a mineralized product with a cellular fibrous stroma. So that's probably that stuff in the middle. And it's mineralized, so that means it would come up radiopaque on a radiograph, right? Clinical presentation of the POF, the peripheral ossifying fibroma. Always located on the gingiva or attached alveolar mucosa, often ulcerated, and may be red or have a normal mucosa color. Firm and may move teeth. Cool. So that's good to know that the POF is firm and may move teeth. But yeah, it kind of just sounds like how you described it earlier. So good to know it's also often ulcerated. Okay. Management and treatment of the peripheral ossifying fibroma. Excisional biopsy. The lesion should be removed down to the periosteum. The adjacent teeth should be thoroughly scaled to eliminate any possible irritants. Treatment for recurrent lesion is re-excision. Treatment for recurrent lesions is re-excision. Okay, cool. And prognosis of peripheral ossifying fibroma is that it has good prognosis, although reoccurrence rates up to 16% have been reported, so that's like not ideal. Then we move on to the other POF, POF 2. We have peripheral odontogenic fibroma, and I really need to like cement these in my head to be able to remember the difference between them. But it looks like the peripheral odontogenic fibroma, again, it presents as like a dome-shaped nodule. Looks pretty sessile. It doesn't look like it's as ulcerated as the other POF, the ossifying one. This one presents on the anterior gingiva papilla, looks like even, and it's like pink and it looks squishy. So yeah, peripheral odontogenic fibroma. Background: it's a true benign neoplasm, soft tissue enlargement that most often occurs on younger patients during mixed attention up to 40 years old generally. True benign neoplasm, soft tissue enlargement that most often occurs on younger patients during mixed attention up to 40 years generally. Clinical presentation: only occurs on gingiva, often facial gingiva of mandible or attached alveolar mucosa. Okay, good to know. So peripheral odontogenic fibroma only occurs on gingiva, often the facial gingiva of the mandible or attached alveolar mucosa. It's firm, sometimes ulcerated, may move teeth. Smooth surface, asymptomatic, well circumscribed, slowly growing, and sessile. Peripheral odontogenic fibroma. Management and treatment, excisional biopsy, and radiographs are essential, and then they have a good prognosis. And this POF has a rare recurrence like the other POF. The next bump gump we move on to is peripheral giant cell granuloma. And I know that this guy moves teeth because the way I remember it is peripheral giant cell granuloma, GC Gomez-Cayley, and Gomez-Cayley are movers, they move shit. So I know that the peripheral giant cell granuloma will be moving teeth, but we'll be talking about that in a little bit. So here this guy is a bad boy for sure. It's definitely still dome nodule shaped. Definitely looks fixed, sessile for sure. I wouldn't really say it's like I don't know, it has like a stalk or anything. You know, it's a wide base. Again, it's presenting in the anterior. Anterior. It looks like mandibular gingiva, in like the incisor premolar canine area. And yeah, what else? Buccally, facially. That's what I meant instead of anterior, but same thing. Anyway, so the peripheral GC granuloma, or giant cell granuloma, background, it's a reactive lesion. It's a soft tissue enlargement that occurs only on gingiva or attached alveolar mucosa. 52 to 60% occur in females, more often in the mandible. Peripheral giant cell granuloma are not associated with hyperparathyroidism. Clinical presentation occurs only on gingiva or attached alveolar mucosa. Peripheral giant cell granuloma is fixed to mucosa. It is vascular, so it can appear red or blue. This one looks like purple, kinda. Red, blue, yeah. It easily bleeds. It's sessile or pedunculated. That's good to know. Firm to palpation, and is often ulcerated. The microscopic features consist of giant cells that are identical to those of central giant cell granuloma. Management and treatment of the peripheral GC granuloma is excisional biopsy down to the periosteum and scale teeth. Radiographs are essential, and cupping resorption may be seen. And then peripheral giant cell granuloma has good prognosis. Reoccurrence is uncommon. Sick. Okay, we are now moving on to pyogenic granuloma, which is also known as lobular capillary hemangioma or pregnancy tumor. And so this guy looks pretty white, red. A small little nodule in between. It's presenting on the facial gingiva in between number 10 and 11, it looks like. Again, in the interpapilla region. So background of the pyogenic granuloma is a soft tissue enlargement that develops as a reaction to a minor injury or irritation. So as a reactive lesion. Clinical presentation, it can be found in any oral mucosa surface at any age, but is most common on the gingiva during pregnancy or puberty. It is compressible, can be lobulated, pedunculated. Ulceration is frequently present. The initial growth rate is quite rapid. In lesions of longer duration, collagen replaces much of the vascularity, and the lesion begins to resemble an irritation fibroma. Lesion is vascular, red, blue, and easily bleeds and blanches. The pyogenic granuloma is well circumscribed and fixed to surrounding structures if located on keratinized mucosa. Management treatment is excisional biopsy. For gingival lesions, we excise down to the periosteum and scale adjacent teeth. For pregnant patients, excision could be deferred until after parturition. I think that's like after they give birth. So yeah, sorry. Recurrent lesions should be re-excised. Prognosis good, but reoccurrence is not unusual. So we have a 3 to 15% recurrence rate. Rhabdomyoma. Background. Rare benign neoplasm of skeletal muscle origin. Found in middle-aged older patients. 75% occur in men. Clinical presentation. It is located only where skeletal muscle is found, so pharynx, larynx, tongue, floor of the mouth, and soft palate. The most common location is the tongue. Can be solitary or multiple, asymptomatic, normal overlying mucosa, and is fixed to surrounding structures. Management and treatment, excisional biopsy, prognosis, and then again, this is a rhabdomyoma, so this is the skeletal muscle. Prognosis of the rhabdomyoma is reoccurrence can occur. Recurrence rate is 10 to 42%. So again, the rhabdomyoma is skeletal muscle origin, rare benign neoplasm, and yeah, cool. On the picture on the tongue, it just looks like a slight raised nodule in the tongue, but it doesn't look like any different. Like, the tongue surface on top doesn't look too much different than the tongue surface around it. It seems like it does have something to do with maybe the tissue inside the tongue rather than tissue that covers the top of the tongue, but it does look a little ulcerated and weirdly shaped a little. So yeah, interesting. Next we have leiomyoma. Leiomyoma is a benign neoplasm of smooth muscle. It is in the oral cavity. It arises from smooth muscle in the wall of blood vessels. It's firm and sometimes has a vascular appearance, which makes sense, right? Because it's in a blood vessel. Firm, sessile, and asymptomatic. It's encapsulated. Common sites are lips, tongue, hard palate, and buccal mucosa. So here's a picture of a leiomyoma. It looks like on the tongue, on the side of the tongue, and it just looks like a little yellow kind of nodule. And there are some red little bumps, which makes sense, right, because of vascular appearance. Encapsulated, and again, common sites are lips, tongue, hard palate, and buccal mucosa. Management and treatment would be an excisional biopsy. Prognosis, it does not tend to recur. Next we have hemangiomy, which is like a birthmark, I would say, technically, but in the when I think of that, I think of like the skin, like on somebody's face or something. But this one obviously presents in the oral mucosa, in the oral cavity. So hemangiomy background: proliferation of blood vessels, which usually is noted at birth or early childhood. Most cannot be recognized at birth, but arise subsequently during the first 8 weeks of life. Clinical presentation: the hemangioma may be well circumscribed or diffuse, and the color varies from red to blue to purple. It may present as a surface lesion or soft tissue enlargement. Often will blanch upon pressure, usually asymptomatic. Common sites are tongue, lips, buccal mucosa, and skin. And then there's a little bullet point underneath that that says arteriovenous malformation is a different lesion. It represents a direct communication between an artery and a vein, and it will demonstrate a thrill and bruit. Okay, cool. Good to know, guys. Next, for hemangiomy, management treatment requires no treatment unless it is a functional or cosmetic problem. Next, prognosis. Many will regress spontaneously during childhood, 50% by 5 years old and 90% by 9 years old. Incision of arteriovenous malformation may lead to fatal hemorrhage. Next, lymphangioma, lymphatic malformation. Background: developmental congenital overgrowth of lymphatic vessels and not a true neoplasm. Hamartorious, which means it's a benign, disorganized mass of cell. In almost all cases, lymphangioma is present at birth or appears during the first 2 years of life, 50 to 7% in head and neck region. Again, this is lymphangioma, which is a lymphatic malformation. Clinical presentation: it is diffuse, poorly circumscribed. Most common locations are the neck and tongue. It can also be found on buccal mucosa, lips, soft palate, and floor of mouth. Tongue lesions can cause macroglossia, leading to problems with eating and speaking, and are usually compressible and fix the surrounding structures. Ew, this is disgusting. Oh, this is so gross. It is described as frog eggs or tapioca pudding appearance. Again, this is lymphangioma, lymphatic malformations. The mucosa overlying the lesion often has multiple nodules resembling small vesicles. Secondary hemorrhaging can often appear vascular. Surface papillations appear vesicular. Management treatment: surgical removal of the lesion is difficult if the lesion is poorly circumscribed. But this is the treatment if it is a functional or cosmetic problem. Sclerotherapy which is vein injections, is also part of the management and treatment of lymphangomia. The tapioca frog egg pudding appearance, and that's what it kind of looks like. Ew, it's so gross. I'm gonna gag on the side of the tongue in this picture. It's so gross. Prognosis can occasionally cause airway obstructions and be life-threatening. Usually to undergo spontaneous regression. Recurrence is common after surgery. Sick. Next we have lymphoma. Lymphoma is a background lymphoma, is a benign neoplasm of adipose tissue. Clinical presentation: it is compressible because when it's encapsulated, may be freely movable based on location. Superficial lesions may be yellow. Deeper lesions may have a normal color. Slowly growing. Management treatment for lymphoma is excisional biopsy. Prognosis: recurrence is rare. In this picture, it looks like it's in like the inner lip, lower lip, and it's just like a little nodule that is yellow. Neuroma: traumatic or amputation. This is disgusting. Sorry, I'm looking at it. I can't tell where this is. I think this is on the tongue. And it's just kind of like a huge little bean shaped nodule, but it's smooth and doesn't have a papilla of the tongue, and it's just really gross. It's like a jelly bean, a big jelly bean that's just sitting on top of the tongue, and it's the same color as tongue, and yeah. So neuroma. Neuroma is a reactive proliferation of nerve bundles following severing of a nerve. Schwann cell sheaths proliferate, and proximal ends of axons attempt to grow through them. Reinnervation is then blocked by an obstruction, which results in hyperplasia of axons and Schwann cells. Clinical presentations: it arises most commonly locations containing relatively large peripheral nerves, such as the mental foramen, tongue, and lower lip. Often, but not always, it is painful to palpation. This neuroma is a slowly growing, firm, and fixed to surrounding structures. Multiple neuromas associated with trauma are part of a systemic syndrome known as multiple endocrine neoplasia type 2, MEN2B. Cool. Management treatment of neuroma is excisional biopsy. Prognosis of a neuroma: lesions usually do not recur but may continue to be painful in the area. Next, neurofibroma. Background: benign neoplasm of Schwann cells and perineural fibroblasts. Clinical presentation of neurofibroma is slowly growing, non-painful. Most commonly occurs as solitary lesion, but multiple neurofibromas are a characteristic feature of the systemic syndrome, neurofibromatosis. Solitary neurofibroma is fixed to surrounding structures and may be firm or compressible upon palpation. Management and treatment: excisional biopsy. Monitor if patient has neurofibromatosis. Prognosis: recurrence is not expected for solitary lesions. Next we have schwannoma. Oh, sorry. And the neurofibroma just looks like a little, honestly, a little sessile nodule, but it's kind of like pill-shaped. And it kind of looks like a pill where it's both of it is pink and there's a line in the middle of it, but one is a darker pink. It's on the side of the tongue and it's the same size, shape as a pill. So yeah, a lot smaller than a neuroma. Next we have schwannoma. Schwannoma, also known as neurolemoma, or benign peripheral nerve sheath tumor. Background: it is benign neoplasm of Schwann cells. Arises in association with the nerve trunk, most commonly in young and middle-aged adults. Clinical presentation: slowly growing, firm, encapsulated, and often freely movable. Most common site is tongue and can be present anywhere, including intraosseous site. Management treatment: excisional biopsy. Prognosis: recurrence is uncommon. This just looks like a huge, bigger than a jelly bean, just a huge nodule on the gingiva, it looks like. Yeah. Schwannoma. Now we have the granulars. Ew. Ew, the granular cell tumor. Background. Benign neoplasm, previously called granular cell myoblastoma. The tumor cells are of Schwann cell origin, found most commonly in people 30 to 59 years of age. Clinical presentation, solitary, frequently, or multiple asymptomatic firm sexual nodule. Color can be pink to yellow. Fix the surrounding structures. The most common location is the dorsum of the tongue, also found on buccal mucosa. Management and treatment. Microscopically, the lesion often appears infiltrative. However, conservative excision is usually curative. Good. And this is just presenting as a unilateral lesion, nodule, pretty big. Oh, it looks more yellow, but there's a little pink dot, and it's on the tongue. Like I said, the most common location is dorsum of the tongue, but the granular cell tumor can also be found in buccal mucosa. And lastly, we have congenital epulis of the newborn. This is just disgusting. It just looks like a little like worm coming out of this baby's mouth, like underneath the tongue. Ugh. Okay, benign soft tissue enlargement that occurs in the alveolar ridge of infants. It's congenital. It usually occurs in the maxilla more than the mandible. Almost 90% of these lesions occur in females. Some can be detected in utero via ultrasound. Clinical presentation of congenital epulis of the newborn occurs only on attached alveolar mucosa, on maxilla more than mandible, on alveolar ridge. Pink to red polypoid smooth surface mass, mostly lateral to midline, developing lateral incisor canine region. Management or treatment is surgical surgical excision, and prognosis excellent, never occurs with incomplete removal. And that is it for the mesenchymal soft tissue enlargements. Benign.